Good evening, sir.
Good evening. So, Asha, you are answering,
Yes, sir.
Sir,
and
today
Asha,
Me and
you,
we,
Brijesh.
sir,
Brijesh is
today Dr.
answering.
Ashay, Dr.
Yeah.
Ankit and Dr. Brijesh will be answering, sir, today.
Okay. We just wait for 2 minutes and start.
Okay, sir.
Okay, sir.
Good evening, sir.
Yeah, Ankit.
Yes, sir. I'm also understand. Just join.
Yeah. Okay, Rahul, let us start.
Yes, sir. A 66-year-old male patient came with the chief complaints of urgency, nocturia 4 to 5 times per night, frequency, poor stream, and straining during micturition, all since 1 year and gradually worsening over the time till presentation.
Yeah. So, Brijesh, how will you go?
Sir, I would like to elaborate the lower urinary tract symptoms. I would like to know the frequency, urgency, nocturia, and I would also like to know whether he had any inconsistency, intermittency, poor flow. Also, I would like to know both of the symptoms and quality of life index, sir. Whether patient had any associative dysuria, lithuria, hematuria, whether there was any history of any instrumentation, catheterization, and whether there was any passage of stone or any hematuria also.
Asha, you want to ask any question?
Asha, you are muted.
Sir, I would like to ask about the IPSS score and then also the other symptoms like hematuria, dysuria, lithuria, and also red flag symptoms of cancer like bone pain also, in addition to what he has said.
So, Asha, what is the significance of IPSS score?
Sir, IPSS score will tell me about the severity of the lower urinary tract symptoms and how how much is it bothersome to the patient, and that will help me to guide his treatment.
Right. And so, a better way of mentioning the presenting complaints will be that I have this 66-year-old gentleman who has come with predominantly storage symptoms with poor stream and straining. I would want to quantify his IPSS score. Then you describe the 7 symptoms of the IPSS score, that this is what I would want to ask. And I would also want to know whether there are any other symptoms like burning in urine, blood in urine, flank pain, backache, constipation, fever. This way, just complete that history. Okay. So go ahead, please.
IPSS score is frequency 4, urgency 4, nocturia 5, poor stream 5, intermittency 2, straining 4, and sensation of incomplete voiding is 3. Total is of 27 out of 35. Bothersome score is 6. Quality of life is poor. Patient is not sexually active.
Rajesh, why are you interested in knowing sexual activity?
Sir, because patient is performing sexually, so I would like to like plan my treatment, and I would also like to know his quality of life index, like whether if I am going to operate the patient, then I would like to counsel him priorly about retrograde ejaculation and incontinence and everything, sir.
What has incontinence to do with sexual activity?
So
Sir,
maybe, sir,
sexual activity.
retrograde ejaculation.
Sir, if the patient is sexually active, then we can, and we wanted to desire his sexual activity, or
No.
though we
Listen.
can offer him.
Listen. If you are planning the medical treatment or surgical treatment, this is very much important. If you are planning for a medical treatment, the drug of choice is alpozocin if he is sexually active. If you are planning the surgical treatment, then in spite of going for a TURP, minimal invasive treatment can be planned if he want to preserve the sexual activeness. So it has impact on the treatment of the patients, either medical or surgical. That should be your answer.
Yes.
So the better way of answering this question will be that I would want to have complete information about this patient by knowing his sexual function, because this is going to help me decide the type of medications and the type of surgical intervention I do when I reach the treatment part. Okay, so this is definitely needed for getting the complete information about the patient. Okay, what else do you want to know now?
Sir, I would like to know whether a patient had any previous history of any lithuria, dysuria, hematuria, whether previous history of any instrumentation, catheterization, any lower limb edema, any bony pain, back pain.
Also, I would like to have a history of constipation
Renal failure.
and decreased urine and pedal edema and facial puffiness, and any history of pelvic or spine surgery.
Why do you want to know about lithuria in this patient?
Sir, since the patient is having both mixed symptoms, storage and voiding ducts, patient may be a recurrent stone formant and patient may present with concomitant bladder outlet obstruction along with bladder or lower ureteric calc, which can give rise to these symptoms.
Okay. ठीक है. You see, with a 1 year history for a lower ureteric stone to present like this is very, very unusual. Okay, and bladder stones would usually not present in this fashion. Anyway, it should be asked, but I would feel that should not come so early in your history. ठीक, आगे चले.
Rahul, go ahead.
Patient was relatively asymptomatic before 1 year, following which he gradually developed increased urinary frequency and urgency. Over the next few months, he began to notice a progressive decrease in his urinary stream along with prolongation of voiding time. Approximately 8 months ago, he developed nocturia, initially 1 to 2 per night, which gradually increased. And 6 months prior to the presentation, his symptoms worsened with increased nocturia 3 to 4 times per night, associated with straining during micturition and a sensation of incomplete bladder emptying. Over the last 3 months, there has been further progression of the symptoms, with nocturia increasing to 5 times per night, marked urgency, and a significantly weak stream.
Yeah.
Proceed.
So, Brijesh, now looking at this history, what do you think?
Sir, he has like worsened the lower urinary tract symptoms, sir, and now it has become severe. So it is really bothering him, and he has a decreased quality of life index. So, sir, I would further evaluate the patient. I would further like to know the history of the patient and all the negative history, sir.
Sir, also since it is slowly growing and chronic pathology, I would suspect prostatic enlargement. Because other
Okay.
causes like lower ureteric cal will present earlier.
My differential diagnosis would be bladder outlet obstruction secondary to prostatic enlargement, which may be either due to benign cause or due to malignant cause, stricture urethra, and lower ureteric cal along with BPH. These the differential diagnosis I will make after seeing the history and taking the history of the patient.
So, okay, if there is a stricture, if you want to differentiate between stricture urethra and enlarged prostate, okay, how will you differentiate clinically? I mean, on the symptomatology.
So, patient with BPH may have predominantly will have hesitancy and will have nocturia episode, and stricture urethra patient will have predominantly voiding, that's straining, sense of incomplete evacuation, poor stream.
Sir, and also
Akshay, can you?
the age profile will be different for
Yes, sir.
stricture and BPA. BPA patient will be elderly, and stricture patient will
Maybe,
be a younger, middle-aged
Not
with
necessary,
history
no.
of instrumentation.
Elderly patient may also have a stricture. You all didn't talk about the stream, no? Stream.
Sir, stream there will be splaying of stream,
नहीं नहीं सर,
splaying of
इसमें
I think thin stream.
considering the age of the patient, stricture can be a differential diagnosis, but down the line, not immediately second diagnosis. I am not denying that
Agreed, agreed.
there may be a stricture, but initially prostate benign malignant bladder outlet obstruction secondary to the BPH or benign enlargement or malignant enlargement, or the vesical calculus, VUJ calculus. These are the things which can be presented with storage symptoms as well as sometimes the obstructive symptoms considering the age of the patient. And down the line, stricture also can. But if you are telling the stricture as a diagnosis, there must be some positive history like history of catheterization, history of passing the stone. ऐसा कुछ तो भी चाहिए कि जिसको हम कोरिलेट कर पाएंगे. Otherwise, idiopathic stricture is the most common type of stricture that is agreed, but that is not in this age group particularly. So this age group is more common with BPH with stone, BPH without stone, malignancy of the prostate. ऐसा कुछ भी पहले 3-4 diagnosis आना चाहिए ideally. And again, the neurogenic bladder, sometimes hypotonic bladder will present same type of symptoms. Detrusor, if it is storage prominent, then detrusor overactivity. These are the some diagnoses which can be considered prior to the stricture, I feel.
Yes. But the only thing is that sometimes the examiners, we have seen, they ask, how will you differentiate symptomatologically that patient has got a stricture or prostate? One of the thing is that when he strains, then the stream will improve when there is a stricture, and there are less chances in the prostate. This is one of the history, which just, clinically it can differentiate between two.
So the basic physics behind that, whatever sir is telling, is the prostate is trilobar. The middle lobe is act like a ball valve mechanism. If he give the pressure to pass the urine, the median lobe will come and block the opening of the bladder, outlet of the bladder. So, and in case of the stricture, if you increases the pressure or if give abdominal pressure, that will increases the stream in case of the stricture. So increase in stream, stricture, decrease in stream after applying the pressure, prostate.
Okay, Rahul, go ahead.
Negative history. The patient does not give history of fever, hematuria, dysuria, lithuria, incontinence or retention, previous instrumentation or catheterization, recurrent UTI, abdominal pain or vomiting, facial puffiness, exertional breathlessness, lower limb edema, or any constitutional symptoms like backache and body ache.
Fine. So now we have come to the end of the history, right? So Brijesh, now next what? We already discussed about the differential diagnosis, and you have given the diagnosis also. Now next, what you want to know?
Sir, I would like to know his any medical history of the patient, whether he's taking any medications, whether he is diabetic, hypertensive, or previous any operative history, sir.
Okay. Now Samit has asked, what about GUTB? So if it is only a GUTB, then what will be more prominent? Which symptoms?
Storage,
Storage symptoms with sir low grade fever and weight loss.
generalized weakness, malaise, loss of appetite, evening rise of temperature,
In history of
Yeah.
TB.
So if
and
Mm,
history of
So
TB
if there is-
contact in the past. There may be
So-
history of TB contact or history of pulmonary tuberculosis to the patient.
So in this case, the chances of GUTB are much, much less. Correct? So I think Samit, you have got your answer. Fine. So Brijesh, now what you want?
Yes, sir. I would like to know the personal history of the patient,
Hmm.
whether he is on any medication, whether he is hypertensive, diabetic, And then I would like to examine the patient.
Yeah, give the personal history.
Past history. Patient is a known case of diabetes mellitus on tablet metformin 500 milligram twice a day, and known case of hypertension on tablet Telma 40 milligram once a day. Patient had a history of urolithiasis which was managed conservatively, and he did not present any documents for the same. Patient gives history of right open inguinal hernioplasty 10 years ago. Family history, nothing significant. Personal history, sleep is disturbed due to nocturia, and habits is a non-smoker, non-tobacco chewer, non-alcoholic, and bladder is altered as described before.
Sir, I would like to have get the history of fluid intake, amount of fluid he is taking, and evening fluid intake, and along with caffeine intake history. मतलब कितना, how much he is taking tea and coffee.
How it is going to help you?
Sir, if the patient is taking a large amount of fluid, then he may have polyuria, which can be corrected by just simple patient education, and we can restrict the fluid intake accordingly. And caffeine and tea intake, alcohol intake irritates the bladder, so it may give rise to urgency, and may contribute
So
to the symptomology.
Ankit, this patient has got diabetes. So will he have the same symptoms
Diabetic
because of
cystopathy
diabetes?
may have, sir, diabetes, but I would like
Polyuria,
to.
polydipsia,
There is,
polyphagia,
Yes, sir.
right?
Yes, sir.
Okay, fine.
yes, sir.
So now just last time also we have discussed. So what is now you want to know about the medications for a diabetes? Why it is important?
Sir, some of the medications like SGLT2 inhibitor are prone to have recurrent UTI, and in a long term, pioglitazone has shown to be carcinogenic to the bladder
Bladder cancer.
and may lead to CA bladder.
What
And
about
in,
metformin?
it may cause lactic acidosis, but it has no direct effect on any symptom. But yes, if we are planning for CT, contrast CT, then we have to stop metformin 24 hours, and we have to resume metformin after 12 to 48, 24 hours after contrast CT. So this thing we have to take into consideration.
Okay, fine. So Rahul, anything significant
No, sir.
in
General examination.
examination?
No, sir.
What about colorectal examination?
Yes, sir. Grade 3 prosthetic enlargement with firm consistency, smooth surface, non-tender. Mucosa was mobile, median sulcus obliterated, and enlarged lateral lobes were palpable. Rest rectal mucosa is empty and no blood on gloves, sir.
Yeah, what else? Brijesh,
Sir, I would like to investigate the patient, sir. Sir, because patient is having grade 3 enlargement prostate in per rectal examination. I would like to do urine routine microscopy, sir, with uroflowmetry, CBC, renal function test, serum PSA, and as he is diabetic, I'd also like to do HbA1c to know how well his glucose is being controlled. And ultrasonography if available for a clinical extension of my examination.
Rahul, just show them the report.
Sir, HbA1c is 6.9 and serum PSA is 2.4. Rest of the investigations are normal, sir.
Can we see the uroflowmetry?
Show them uroflowmetry and sonography, which he has asked.
Yes, sir.
Can someone read the sonography?
So this is ultrasonography of KUV region, which is showing bilateral kidneys to be normal. Bladder is adequately filled uh, with mild thickening present, and there is prostate seems to be heterogeneously enlarged and with intravesical prostatic extension.
So better term will be intravesical prostatic protrusion.
Protrusion.
Protrusion. Okay. How do you look for bladder wall thickness?
The patient bladder should be adequately filled till 150 to 200 ml, and then we measure the distance between the hyperechoic mucosa to hyperechoic adventitia. This distance, if more than 5 mm, is suggestive of bladder outlet obstruction.
So where do you measure?
Sir, in the anterior wall.
So where?
At 3 places.
Anji?
So at 3 places in the anterior wall of the bladder.
And then you look at the mean.
Yes.
Okay. And what is the normal bladder wall thickness?
Sir, less than 3 mm.
Less than 3 mm. Very good. And what is the significance of IPP?
Sir, if the patient is having intravesical prostatic protrusion, then the chances of medical treatment being successful is less likely, and chances of progression and acute urinary retention, chances of progression of disease is high, and yes, sir.
Fair. Okay, so what else do you want to see in this sonography? Have you looked at the post-fired residue?
No, sir. So we have to look. Actually, film sir dikh nahi raha. I'm not able to see.
You are not able to see. I think, yes, yeah, I agree that the images are not very good. So can you give the report, please? Hello.
Yes, sir.
Rahul,
Yes,
just
sir.
show the report.
Yes, sir. The prostate is enlarged in size and measures 4.3 by 6 by 5.3 centimeter, volume of 73 cc. Pre-wide urine is 386 and post-wide is 113 cc. Upper tract is normal.
Show them uroflowmetry.
Yes, sir.
Okay, Ankit. Now, what do you like to do?
I will counsel the patient about his disease process, and I would like to offer him. I will tell the patient what are the options we have, and I will start patient on. After telling that there is less chances you may get benefit for medical therapy, but still initially I want to start patient on medical therapy, that is combination therapy with alpha blocker and 5-alpha reductase inhibitor, and I will assess the patient after 1 month.
If you are convinced that he is not going to improve, why don't you offer him surgery?
I just want to give him first I would like to give him medical treatment first.
So what are the total indication for surgery.
Sir, patient refractory to refractory to medical treatment, recurrent UTI, refractory AUR, hematuria, upper tract deterioration with renal function deterioration, are these absolute indication of surgery with and relative indications are bladder calculus and bladder diverticulum.
So in this case, if you are offering him medicine, what medicine you want to offer?
I would, since the patient is not sexually active, we will like to give him uroselective alpha blocker like silodosin along with 5-alpha reductase inhibitor.
What is the reason? Justification.
Sir, since the gland is more than 40 cc and PSA is more than 1.6, so as per latest EAU guideline, I like to offer him combination therapy.
The effect will come after how many days, months, or years?
Sir, the 5-alpha reductase effect will come after 6 months, whereas the effect of alpha blocker will come within 3 to 4 weeks.
3 to 4
weeks, sir.
Now, in acute retention, which is the drug of choice?
Sir, silodosin.
Why?
So because it is rapid, its action is rapid, sir.
How much time?
Sorry, sir. Don't know.
So when patient comes with retention of urine and you have catheterized and you have given him silodosin, or there is a even alfuzosin if you give, okay. After how many days you remove the Foley's catheter?
You
Sir,
said the action is rapid.
3 days, sir.
Yes, sir. 3 to 5 days, sir.
Then why are you saying 3 to 6 months?
Sir, 5-alpha reductase after 6 months and alpha
That is
blocker.
okay, but silodosin,
yes, sir.
you said rapid action, but you're saying months.
Usually with silodosin, you should see good response within 1 week of medication. So 3 to 4 weeks will be a very long period. And when you give trial without catheter, you should give alpha blocker for a minimum period of 72 hours. Okay.
So yeah, go ahead.
नहीं सर, आगे का केस आपको पता है, बताइए.
Yeah. So okay. So your Ankit, as per your suggestion, we should start silodosin and dutasteride, correct?
Yes, sir.
What is the difference between dutasteride and finasteride?
Sir, dutasteride is dual blocker. It acts on both isomer of 5-alpha reductase, type 1 and type 2. Whereas finasteride acts only on type 2, sorry.
So what is an advantage?
Sir, so more complete suppression of the dihydrotestosterone will be there with dutasteride. And finasteride will provide only like 50%, 70% suppression.
Second advantage of both mainly
So faster
dutasteride?
action of dutasteride compared to finasteride.
Okay. Third,
The decreased vascularity and androgen-dependent adenoma formation.
so it's a big gland, and if you are planning for a resection, right, there are some chances that vascularity may be reduced. And the bleeding may be less. Is there any literature supporting this?
I'm not aware.
Maheshwari ji?
So there is a literature saying that this 5-alpha reductase inhibitors reduce the vascularity and reduce the bleeding. But I don't think I have read any literature where advantage of one over other for reduction of bleeding. At least I am not aware, sir.
Even I am not aware of that.
ठीक है, sir. So either of the two can be given, and I agree that there is a more complete block, faster response. Otherwise, over long run, the response of both, as far as the reduction of prostate size is similar, the side effect profile is similar.
Fine. So now, Ankit,
Yes, sir.
what is the side effect of silodosin?
Sir, fatigue, dizziness, asthenia, then retrograde ejaculation.
Is it retrograde or an ejaculation?
Sir, an ejaculation.
And how many percentage?
Percentage, I don't know, sir.
They earlier they were saying 25, and I think it is more than 70 to 90%. Pankaj bhai, what is your view on that?
No, sir, I don't think it is 75 to 90%. It is around 30 to 40%. But even I will need to look up the exact percentage, sir.
Yeah. Okay. So once you start this medicine, why not alfuzosin? Why not the thing, tamsulosin? Brijesh, can we start alfuzosin, tamsulosin?
Sir, patient is already sexually inactive, sir. And tamsulosin and alfuzosin, silodosin has better CVS and nocturial. Silodosin has better nocturial symptom coverage of nocturial symptoms compared to tamsulosin, alfuzosin, sir. And also, it is more compatible with antihypertensive drugs. So it is better to start silodosin.
What is the role of tadalafil?
Yes, sir. Tadalafil
PDE5
also.
inhibitor?
Yes, sir. Tadalafil also relaxes lower urinary tract and prostatic urethra, sir. And it can help in reduction of prostatic inflammation, sir.
Editing increases the vascularity of the bladder, so anti-inflammatory action is there.
So if this patient doesn't improve, will you add that medicine?
Yes, sir.
Ashay? Okay, fine. Anyway. So, okay, we started medicine. Now patient has not improved.
Patient was managed with medical therapy for 1 month and followed up. Patient had no improvement of symptoms and came with the following uroflowmetry pattern.
Yes, Brijesh. Now, what is your approach?
Sir, I would like to counsel the patient, sir, because his prostate is 72 grams, sir, and there is no any significant improvement in uroflowmetry, and also after medical management, and he also is a diabetic. So chronic retention with the diabetes can also land him up with upper tract changes and urinary tract infections. So, sir, I would like to counsel the patient that he will require surgery, sir. And I would explain the different modalities of the surgery available for him and would like to proceed further accordingly.
Ankit, what is your view?
Sir, I would like to reassess the patient with his IPSS score, his quality of life index, and with bothersome index. If it is on a decreasing trend, if the IPSS score is increasing, then I would counsel the patient regarding the surgery. Otherwise, I would like to add tadalafil and would wait for another 2 weeks, 2 to 4 weeks, and then proceed after counseling the patient that he may require surgery now.
Ashay, what do you think?
Yes, sir. I would like to reassess his symptoms and then explain to him the option of continuing the trial of medical therapy and versus surgery, which will provide rapid relief, and explain to him the complications of surgery as well. And through shared decision making, we will proceed further.
Now,
So,
do you
Asha and Ankit, I'm not understanding one thing. So, this patient, there is no improvement with medical management. The flow rate, instead of increasing, has rather gone down.
Yes, sir.
Why? What is the reason for continuing medical management at this time?
Sir, with the patient IPSS score, that's why I was I would assess the
So
IPSS
they have
score and
already
bother
said that there is no clinical improvement.
So then if the IPSS score is not improving or this bothersome index is high, then I will definitely counsel the patient regarding the need of surgery.
देखो, decision of surgery is not depend upon any one factor. Listen, increase in post-void residue, bothersome symptoms, then the failed medical treatment, associated complications like bladder stone or the obstructive changes in the bladder, bilateral hydronephrosis, decreased renal function, hematuria. There are fixed indications. So it is not only decided on only one factor. So you have to combine all the factors and decide if surgery is needed or not, and the type of surgery also as per the requirement you have to decide.
second thing is this patient has got diabetes, plus he has got a residual urine. So now diabetes with the residual urine, chances of infection also myopathy. So as you prolong, so if the person is not having diabetes, not much of the residual, then it may be a little different scenario. So as Dr. Gite said, not one factor, all these factors you consider, and then you say that what you want to do. So Ashay, now what is your choice?
Sir, so for in this patient, I would like to consider this as failure of medical therapy with bothersome LUTs, and then I will convince the patient for surgical management. I would like to go for bipolar TORP.
Okay, Ankit, what is your choice?
Sir, I will counsel the patient regarding the need of surgery and I will give him the option of available treatment like bipolar TORP or anatomic enucleation of the prostate or yes, sir.
If he says that I want some new method,
Yes, then I would counsel the patient and tell the patient about the aquablation or rhizome therapy or urolift.
you think Urology will help him?
Sir,
Sir,
Rahul,
Urolift
just
is
show him the
preferred in cases
sonography.
where we prefer
sir, there
prefer
is
to preserve ejaculation, and in this case, he is not sexually active, so might not help.
median
And
lobe, sir.
enlarged median lobe.
Then, so Ankit, whenever you are answering, all these factors, practical things also you must take it in view, and then only then you answer. Just see how much median lobe is quite a big. Here
Yes.
they have not given you. See
Yes.
on the left hand side, second one, you can see. Okay.
Which mist can be done in a patient with medial lobe, Ankit?
Sir, rhizome or aquablation?
Is aquablation a mist procedure?
Sir, it is a robot.
Hmm.
Yes, it can.
Robotic water.
Robotic, sir.
But does it come in the list of mist procedures?
Yes.
See, the definition of mist is that patient, it should be OPD procedure, there should be less need of catheter, There should be less need of anesthesia. Uh, uh, how is aquablation done? Do you know what is done exactly?
Sir, under the direct thrust vision and 18 gauge scope is under the anesthesia. Patient would be placed in lithotomy position, and in the direct thrust vision, we uh, uh, mark the area where the steam has to be installed, and we do the scope insert the 18 pre-packed scope is there. So we insert the 18, it comes at of a size of 18 French, and we insert it, and from the we inspect the whole of the prostate from bladder neck till value, and 1 centimeter distal from the bladder neck we start giving steam for a period of 9 seconds, and we come
You will give
proximity.
steam in aquablation.
Sorry, water jet. Sorry, water jet. Water jet, sir. Under.
So, what part is ablated in aquablation?
Both lateral lobes.
What about medial lobe?
No. Sir, I'm not sure.
Brajesh?
For sir, a lateral lobe, sir. Medial lobe and bladder neck is spared in installation.
नहीं भाइयों ऐसा मत करो. You see, so in aquablation, you ablate from 10 o'clock to 2 o'clock. Okay, so 10 o'clock to 2 o'clock towards the roof is spared. Everything below is ablated. Okay, so aquablation is a very good procedure for patients with medial lobe. You do not spare bladder neck or median lobe here. So you would mark the median lobe, you would mark the lateral lobe still just distal to the verumontanum by truss and by the endoscopy examination. And then with a high pressure water jet under a robotic control, it is ablated. The depth of penetration of aquablation is around 24 millimeters. So if the thickness of the prostatic tissue is more than 24 millimeters, then it would need second pass. So first time you do it, and second time you again mark and you ablate further. So this is a procedure for patients with median lobe, but aquablation is not a part of MIST. Aquablation helps in maintaining antegrade ejaculation. Not every procedure that maintains antegrade ejaculation is MIST. Okay. So as per today, there are only 4 procedures which should be qualified as MIST. Prostatic urethral lift, water wave thermotherapy, then your Optilium, and which is the fourth one?
Sir,
iTind.
Haji?
iTind.
iTind.
Olympus.
So these are only 4 procedures which come under MIST. There are a lot of new implants which are coming up. So there is butterfly, there is a spiral implant which are coming up, which would come under MIST. Aquablation and prostate artery embolization are procedures, but they don't fall under the category of MIST. Okay, so both may help in reducing retrograde ejaculation. So if facility is available, if there is a large prostate, if there is a large median lobe, then aquablation could be one of the ways to go. Now, aquablation would be useful for patients up till 150 grams. Okay, so up till 150 grams, you will have aquablation and resume. Why resume can be done till 150 grams? So they say that for every injection of steam by resume, it approximately takes care of around 10 grams. And maximum injections permitted by one hand instrument of a resume is around 15. So that is the upper limit. Though as per guidelines, it is to be used for patients up till 80 grams. So beyond 80 grams, try not to talk about MIST procedures. And if you have a patient with median lobe, then there is only one MIST procedure that would work, that is water wave thermotherapy or resume. Okay.
Really?
How does Optilium work? What is Optilium? Yes, Ashay.
Sir, in Optilium, uh, it is like balloon dilatation, drug coated balloon which is inflated and which acts to reduce the.
What drug? How does it reduce? What does it do?
Sir, I don't remember.
Anybody else can take. Brijesh, Ankit.
Sir, the drug which we give is paclitaxel, sir.
So you don't give, it is a paclitaxel coated balloon.
Coated, sir.
Okay. And it works by creating an anterior chamber. So it creates a tear at the roof between the two lateral lobes, and there paclitaxel will be released. Paclitaxel is an anti-fibrotic agent. So it doesn't allow healing by fibrosis, and so an anterior chamber will be created. Remember that Optilium, the balloon size is comes in the 4.5 and I think 5.5 centimeters. So that is the only procedure where you would take into consideration the prostatic urethral length before deciding the choice of the patient. Okay, so you have to choose a prostatic urethral length which is 1 centimeter less than the size of the balloon. So more than 4.5 centimeters prostatic urethral length, Optilium cannot be done. Coming to Urolift, Urolift possible only for lateral lobes. It doesn't work for median lobe, though there are some new studies which is called as midlift protocol, in which a small median lobe can be pulled in the prostatic urethra and it is attached to one of the lateral lobes. But that is useful only for small median lobes, and you should talk about it when asked about it. But if the patient has a median lobe, don't suggest prostatic urethral lift. Again, as per guidelines, it can be done up till 80 grams. You will need to put multiple clips if the prostate size is large. Okay.
Okay.
And iTind is useful only for patients with small prostate with bladder neck obstruction. Though again, guidelines or the literature says that it can be used till 75 to 80 grams, but in practice, it would be used for small prostates with predominant bladder outlet obstruction. The iTind is placed in such a way, it has three wires. So it will cause three cuts, one at 12 o'clock, 5 and 7 o'clock. That happens by pressure necrosis. It is kept for 5 days and removed after 5 days. Okay, so these are your 4 mist procedures. So in this patient, if you have to use a mist, then the only option is water wave thermotherapy. Okay. Now, when you talk about the treatment option for this patient, one of you said bipolar TRP. The one other person, I don't remember who it said, has said I would give option of TRP as well as AEP. I think that is the better way of talking about it. The prostate is nearly 80 grams. So you can say that in my hands, I will not be able to complete the resection in one go. If the patient is willing for 2-stage procedure, then I would do TRP. Otherwise, a better option would be to go for AEP.
Okay.
Okay.
Any questions about mist or treatment selection?
No. So when you will do prostatic artery embolization? Nowadays, well, many patients they come and they ask you, "Okay, sir, can we do this?"
Sir, indication of prostatic in frail elderly patient or patient who are not fit for surgery. These are the primary indication for prostatic artery embolization.
Any prostate?
With large prostate.
Large prostate.
Even in a frail patient with a 30-gram prostate, you would not do PAE. Okay, so the minimum size of prostate you would need is around 40 to 60 grams. Okay. So patients with large prostate, frail, unfit for any indication, PAE could be one of the options. But you should say that as per the present guidelines, it has been quoted as an experimental treatment. I would give this option to the patient, telling him that the possibility of coming out of catheter for this patient would be around 60%. This figure you could just recheck about the coming out of catheter. The last I remember, I think probability is 60%.
Fine. So, but Ankit, what is the gold standard?
Sir, bipolar TURP.
So, TURP is the gold standard. Suppose if you are doing a monopolar TURP. So, in your institute, you are regularly doing bipolar or you are doing monopolar?
So we are doing bipolar.
All the cases?
Yes, sir.
So, then what are the complications of bipolar and of monopolar?
Sir, sir, in monopolar TURP, the chances of TURP syndrome is higher as compared to bipolar TURP. Then chances of bleeding is more in monopolar TURP, and vision is poorer in monopolar as compared to bipolar.
Poorer? Vision is poor in bipolar or monopolar?
Sorry, bipolar, sir.
Okay. So, what is the TURP syndrome?
Sir, serum when the serum sodium comes below 125 milliequivalent per liter, then and with sign and symptoms of hyponatremia, this is known as bipolar. This is known as TURP syndrome, sir.
So what
Dilutional
happens?
hyponatremia with fluid overload due to absorption of irrigation fluid
From?
from
Open sinuses or
the
capsular
venous
process.
sinuses.
From the sinuses.
Yes.
Correct?
Yes, sir.
Yes, sir.
So now you tell me initially how the sequence, sequence wise, how it happens. Signs and symptoms. Just tell me.
Sir, if
When you're doing QRP with a monopolar, what will happen?
sir, the initial sign and symptoms is restlessness, yawning of the patient. If the patient is in spinal anesthesia, in general anesthesia, we catch hold of the symptoms late. But when the patient is in spinal anesthesia, the yawning, restlessness, pain, then
Headache,
headache,
nausea,
and then
nausea, vomiting.
and patient may have hypertension, bradycardia, then followed by hypotension.
Okay.
And if
And this is
glycine
all
is
because
used,
of
then vision
Sorry,
problems
sir.
also.
absorption of water giving rise to hyponatremia, edema, and even edema in the chest, lungs, and as well as in the
Pulmonary.
brain.
Cerebral.
Correct?
Yes, sir.
Yes, sir.
So what is the treatment?
Sir, we should abandon stop the surgery immediately and put the Foley's catheter and start the patient on 100% oxygen and monitor his vitals.
And
And then
send electrolytes.
post-op fluids we should restrict, not
And
give fluids.
and immediately we
And
should
so
give
what fluid will be?
lessons.
measure sodium. And if it is severe, if there is severe hyponatremia, if it is less than 120, then we can consider giving 3% hypertonic saline also.
And
And
along with
also
that, what you will do?
intraoperatively we can give
Sir,
injection
we can give
Lasix,
Lasix injection
furosemide.
or mannitol injection, sir.
Okay. So how much Lasix, how much mannitol?
Sir, Lasix 40 milligram or 1 milligram per kg. This is the ideal dose. And Lasix is 100 ml, sir.
Lasix 100 ml.
Yes, sir.
Mannitol.
Mannitol, sir. And Lasix is 1 milligram per kg, sir.
Mannitol 100 ml.
Lasix is 1 milligram per kg body weight, sir.
As per blood pressure Lasix.
Okay. And what fluid? Okay, saline you will give, correct?
Yes, sir.
Even though patient has got
Yes.
hypertension, still you like to give saline. Fine?
Yes,
Correct?
sir.
No, you're right.
Yes. Yes, sir.
Oh, yes. Okay. And in the severe cases, what happens?
In severe
Suppose if you
hyponatremia, we
don't
can
notice,
correct.
Patient may
doesn't
have seizure, patient may have severe pulmonary edema, respiratory failure, and may land up in coma.
Coma.
Or
Suppose you're bleeding, you're doing a TRP, the bleeding is not stopping. Ashay?
Sir, if the I would like to increase. I would like to try to do hemostasis as much as possible, even if it is not stopping that time. Then I will. I would like to uh, use the roller ball for coagulation and check my instruments if irrigation is proper, and then I will abort the procedure if it is. I would ask the anesthetist to give injection tranexamic acid, and also if it is not getting controlled, then also then I would like to uh, abandon the procedure and then put a Foley's and put
No, you
traction.
have put the police, bleeding is continuously there and it is getting clotted. Now what you'll do?
Sir, first bladder washes to remove the clots, and then continuous bladder irrigation. And even if it is not stopping, then
First of all, we have to differentiate whether this bleeding is arterial or venous.
re-endoscopy and
If it is venous, it will stop, now with
Yes,
the
sir.
pressure.
Yes,
yes,
sir.
sir.
But
Yes,
if
sir.
it is arterial, then we have to stop the bleeding because it will continue. If it will
No,
continue
it
to
is
bleed.
not stopping. I'm asking you the question. What is the next step?
So, resuscitate the patient, give blood transfusion, and then reattempt cystoscopy and coagulation using roller ball cautery.
Arey Baba, you already tried.
So, then we can go for interventional radiology, DSA, and angioembolization.
You don't want to do, and when you are already on the table, you don't want to do anything.
Sir, I would first like to see the blood pressure of the patient, sir. If his blood pressure is very high, his hypertension is not controlled, then I would like to give intravenous antihypertensive medication. Even if after doing multiple maneuvers and recheck cystoscopy and clot evacuation, if bleeding is not stopped, then I would like to get the guidance of some of the senior consultant and like to put roller gauze in the prosthetic force and tie it with uh, police catheter and
Okay, so before that, what you like to do? So you are opened up, Vijay. You are
yeah.
opened up. So probably you are opened up. You open up the bladder. Now what you will do?
I would like to, sir, give direct compression over the bladder
Is
with
there any maneuver?
The Malament maneuver and headset maneuver.
So can you take some stitch?
Sorry, sir.
Can you take some stitch?
Yes, so we can take
Second.
suture at 5 and 7 o'clock position, at figure of 8 suture at 5 or 7 o'clock position, and plicating
Where?
suture.
What the stitch is called as?
Sir, Malament.
Correct.
Yes. So where you will take the stitch?
Sir, at 5 and 7 o'clock position
At the
Okay,
bladder
fine.
neck.
So you have
at
taken
the
a
bladder neck.
good stitch at the bladder neck. Now it is not stopping.
Then we will take a plicating suture over the prostatic fossa.
Then not stopping.
Then trigonization.
Then
No, so you
check
have taken all the
open
stitches.
prostate.
Then ligation of the prostatic artery, or sorry, ligation of the inferior vesical artery, sir.
Okay, fine. And still, if it is not stopping,
Internal eyelid.
no,
Unilateral.
before that, just pack it. No? Most of the time, once you pack the fossa under pressure and keep it for some time, it will stop. So now you have packed the fossa, you have kept the roller gauze. What you will do next? It has stopped. Bleeding has stopped.
Then we will close the we will put the 22 French 3-way Foley's catheter and inflate the balloon approximately 30 to 40
Traction.
ml and give a traction.
And the roller gauze will be below the balloon or above the balloon?
So below.
Below. Okay. Then will you like to?
And we will take out the roller gauze through this stab skin incision, and we will close the bladder in 2 layers and put a drain and suprapubic we will suprapubic catheter, and we will remove the roller gauze after 48 hours.
If there is no bleeding.
If there is no.
So now, if you are going to put a suprapubic, you want to put the 3-way or 2-way police catheter?
Two-way.
2-way. So now you tell me, Ankit, step by step, how will you do?
So,
the patient is bleeding, you are doing TRP, patient is bleeding, you have given a bladder wash, you have tried to coagulate, you have used the roller ball also, you are not able to coagulate, and patient is bleeding, you have given a traction, you have given irrigation, is getting clotted, patient is also going into little hypotension.
We will immediately open
and
the
you have
patient.
resuscitated, you have got the blood, everything is there. Now tell me step by step, whatever you have said.
Sir, first we will open the patient with lower midline. Sir, we will open. We will give a lower midline vertical incision and then open the bladder. Then we will put a after taking a stay suture over the before taking a stay suture, we will fill the bladder approximately 100 to 150 to 200 ml and take a stay suture, and we will make a neck vertical cystostomy. Initially, we will make a small hole, and then we will suck out all the fluid, and we will extend our incision till the for 3 to 4 centimeter till the bladder.
You open the bladder, you're inside. Yes. Now tell me.
Step by step. Yes, sir. Then we will
what are the procedures you will do now?
Sir,
number one, what you will do?
First of all, we will put a roller bandage and give a pressure over there, and we'll wait for 10 to 15 minutes. If then bleeding is still going on, we will if the bleeding is still going on, then we will take a suture at 5 and 7 o'clock position. If it's still.
So first you will take a suture, or first you will put a roller gauze?
Yes, sir.
What you will do first?
Sir, first of all, under vision, we will with electrocautery, we will coagulate the visible bleeding vessels. Then after that, we will give a we will pack the prosthetic fossa with roller gauze, and we will wait for 10 to 15 minutes. If again if there is bleeding, then we will take a 5 and 7 o'clock.
Actually, what you will do first? First you will take a stitch, or first you will put a roller gauze?
So first compression, then coagulation, then stitch, and then roller gauze.
So first you like to take a stitch, correct?
Yes, sir.
And then, as you said, vesical vessel, you like to ligate. Still, it is not stopping. Then you'll put a roller gauze.
Yes, sir.
Sir, roller gauze is a last resort. After using all the techniques to control the bleeding, if it is still not getting control, then the packing is the last resort to control the bleeding.
Exactly. So please understand. That is why I am asking you step by step. So what you should say is, after endoscopic, I will try to coagulate. If it is not happening, immediately I will open up the patient. I will take the stitch at 5 o'clock, 7 o'clock. If still that is not, bleeding is not stopped, then the next, if possible, I will take the vesical, vessels control. That is also not working. Then you will put a roller gauze and bring it out from top. Put the periurethral catheter above the roller gauze, inflate it, give the pressure, put the suprapubic, and come out. Provided the bleeding has stopped, correct? Usually it stops. Fine. So after 48 hours, you will remove. Okay. Pankaj bhai, any other question, or we can go ahead with the second case?
I think, sir, we can proceed.
Okay. Fine. Rahul?
Yes, sir. Doing.
Second case.
A 66-year-old male patient came with a complaint of increased frequency of passing urine since 6 months, nocturia since 4 months, and the above symptoms have worsened over the period of time.
So let us go fast. Now, just you give the full history now.
Yes, sir. The IPSS score is in here 16 out of 35. Bother score is 5. Quality of life is 4. Patient is sexually active. Patient was relatively asymptomatic before 6 months, following which he gradually developed urinary frequency. The frequency increased over the months, and patient says that he has to pass urine every 1 to 2 hours at present. Over the next few months, he began to feel that he had occasional episodes of urgency as well. He also complained of sensation of incomplete emptying of the bladder since 1 to 2 months. Approximately four months ago, he had nocturia, initially 1 to 2 times per night, which increased to 4 to 5 times in the night till now. Patient also gives history of stopping and starting of urine in the midstream since few days. Shall I go ahead, sir?
Yeah, go ahead, go ahead. Finish up.
The patient does not have history of hematuria, dysuria, lithuria, incontinence, or urinary previous instrumentation or catheterization, recurrent UTI, or any abdominal pain, nausea, vomiting, or any constitutional symptoms. Past history: patient is a known case of hypothyroidism since 10 years, and bowel and bladder habits are altered as described before. Sleep is disturbed as described before. Habits: patient is an occasional tobacco chewer, non-smoker, non-alcoholic. General examination is normal. Per abdomen examination is also normal, sir. This is the per rectal examination. Grade 3 enlargement,
Okay.
firm consistency.
Yeah,
Yes, sir.
fine. So again, old question, Bridges. How in PR, how will you grade the prostate? Because this is normally asked in all the exams.
Yes, sir. Sir, if entire prostate, like tip of the prostate is palpable, then it's grade 1, sir. If median sulcus and can difficulty to reach above, just above the tip, there is grade 2, and it's not able to reach above the prostate, grade 3, sir. We would also like to see nodularity, surface, and its adhesion to rectal mucosa, whether there is bleeding or not.
Okay, fine. Now this is the history and examination. So Bridges, now next what?
Sir, 66-year-old male with predominantly storage and as well as voiding LUTs with moderate IPPS score and poor quality of life index. So I would like to further evaluate the patient, sir. Like I would like to know urine routine microscopy, CBC, RFT, PSA, and also uroflowmetry and ultrasonographs.
Yeah. So then, Rahul.
Yes, sir. His HbA1c is 7, PSA is 3.7. Rest of the investigations are normal, sir. Moving forward.
Sodium is 132.
Sodium 132, sir. Yes, sir.
Okay. Next. First cells are 7 to 10.
7 to 10 per cells with 5 to 7
Culture.
epithelial cells.
Blood
It's a
culture negative.
urine culture. It was typing mistake.
PSA was normal. Okay. Ankit, will you like to read the sonography report?
Yes, sir.
So we also have another sonography image after this.
Show them.
Yes.
This is a USG whole abdomen and pelvis showing liver and gallbladder to be normal. The bilateral kidney seems to be normal, and the bladder is adequately filled with the increased bladder thickness, and there is hyperechoic shadow with posterior caustic shadowing seen in the bladder, so, which may be calculus. Can Yes, sir. And with the enlarged prostate with intravesical prostatic protrusion seen.
Okay, fine. And I will show them the report.
Urinary bladder is well distended and shows mobile echogenic calculi of size 8.3 millimeter. Other calculi are also seen with wall thickening, maybe due to chronically enlarged prostate. Pre-void volume is 109 cc, post-void is 24. Prostate is grossly enlarged, approximately weight is 97 grams, with evidence of foci of calcification and projection of median lobe into the bladder.
Okay. Uroflowmetry. So Ashay, now this is a patient, this is a history, and these are the investigations. What you would like to do?
Sir, since he is having bladder calculus, which may cause
Before
complications
that,
like
how do you interpret this Euroflow report?
So this is patient is having hesitancy along with intermittency with blunted pattern with both hesitancy and intermittency is seen.
hesitancy.
And what about the peak flow rate?
Sir, the Qmax and the average flow rate are not matching, sir.
So how do you interpret that?
Sir, as patient is also having a vesical calculus, sir. So this Euroflow may be little bit fallacious, we can say, sir. Because
So what does vesical calculus do to the Euroflow?
Sir, when the bladder it comes at the bladder neck, it might obstruct the flow, and that's
So
why the
intermittency probably can be
intermittency is
explained
due
by
to the.
this. Okay.
Yes, sir.
But how do you explain this 16.5 ml peak flow rate, which is coming in near normal range?
It might be due to straining done by the patient.
So remember, you see, on a Euroflowmetric curve, unless the peak goes more than 3 seconds, that peak should not be considered. So just a single spike going up and coming down, even if it goes any high, that is not to be considered as significant. So that's a very small, narrow peak. So we would not take that into consideration. We would take the other part. So like, if you can see my arrow, I would not consider this part. I would consider probably this part as the peak flow rate, which will come less than 10.
Okay.
You understood, man? So what I wanted to show was this single spike, which is less than 3 seconds, should not be considered as the flow rate. Okay.
Yes, sir.
So here we have a prolonged wide intermittent stream and low peak flow rate. Okay, good.
So, what are the different types of vesical calculus you come across?
The primary and secondary, sir. And third is migratory.
So, what type of stone is this?
This is secondary stone, sir.
Can it be migratory? 8
It could be,
millimeter.
but
It can
sir,
be, sir.
it can be.
It
could be, but most probably it is secondary vesical calculus, sir, due to bladder outlet obstruction. Since in USG we are not seeing any calculus there is no hydroureteronephrosis, so there is chances that there may not be any lower ureteric cal.
Okay. So now, Ankit, now this is Dr. Pankaj Maheshwari has explained you very nicely about the uroflowmetry. Just one peak, okay, which gives rise to 16.5 ml per second should not be considered because it is just less than 3. Because that is suddenly patient strains or something. One peak may be there, but that is not the actual flow. So
Okay,
if you see the first peak is, I think what he says is right. It is less than 10. Now what you want to do?
sir, I will advise patient. I will counsel the patient about his disease process and about the condition, and about the diagnosis that he's harboring. He is having bladder outlet obstruction secondary to benign enlargement of prostate along with vesical calculus. So this is a relative indication. And since he is having bothersome symptoms and his IPSS is 16 and bothersome index is 5 by 6, so I will advise patient a surgical management, sir. And his prostatic size is more than is very, he has a large prostate.
But he has
Sir,
never taken a medical management. You don't want to offer him?
sir, because he has a bladder calculus, both the pathologies can be addressed in the same surgical setting rather than just treating the stone and then keeping him on medical management.
No, but these patients, sir, doctor, you remove the stone. Don't do anything to the prostate.
So then we
Sir,
will
we can do it, sir. We can do
tell.
it, and we will. There are studies which have shown removing the bladder calculus may improve the symptoms. But I would inform the patient that there are 50% chances that your symptoms will not improve or may get worsen. So it
And
will be.
recurrence
Yes, you want to give medical
of
management
stone.
and wait?
No, sir, I would like to counsel the patient because patient is having already significantly enlarged prostate with secondary calculus. So I would like to counsel him that despite removal of the calculus, there are more chances, around 40 to 50% chances he may land up in more worsening lower urinary tract symptoms. And so he would better be treated with, it would be better if he gets treated with surgical management.
Yeah, the patient is little smart. He says that doctor, I feel that the stone is coming and obstructing me. That is why my flow is interrupted. If you give me a medical management and if you remove my stone, and then if we wait for 1 or 2 months, that is his suggestion. What do you think?
Sir, if the patient is comfortable with the rate of recurrence and if he is giving consent only for cystolithotreated, then we will proceed with it.
So what are the chances that you do systolithotreating, you give him a medical management and avoid surgery?
Sir, I would like to counsel the patient like I would do as diagnostic cystoscopy, would see the anterior urethra, posterior urethra, bladder neck, and prostate and evaluate, and concomitantly will remove the vesical calculus. But taking in consideration that if he has any secondary changes like trabeculations and blood cystopathy because of bladder outlet obstruction, I will also take the consent and ask him. Then I can operate.
Brajesh, why do you need cystoscopy for this? Your sonography has shown a significantly thickened bladder. You have seen a huge IPP in this patient. So how will cystoscopy make you any wiser? Show the images, please. So here we can see a very, very large IPP here. In the last image here, there is a big IPP here. And we already see this double line. So there is a thickened bladder.
Yes.
Okay. In these first two images, the bladder wall looks extremely thick.
Yes.
So how will cystoscopy help you?
I stone is sir significantly smaller as compared to the enlarged prostate, sir. If patient is relatively adamant that he doesn't want to get operated for the prostate, then just we can next time if he's going to get lower urinary tract symptoms and acute urinary retention, then we would have probably a roadmap what we are going to deal.
So cystoscopy you are doing to remove the stone, not to get all this information.
Sir, concomitantly, I will do both, sir. First, I will visualize the anterior urethra, posterior urethra, and if it comes out with a 25 number sheath, then I would remove the calculus in toto and proceed further.
Okay.
Sir,
So
if the
what's
prostate was smaller, then we would have considered medical therapy. But for 90-gram prostate, there will be a large mechanical component, and even 5-alpha reductase inhibitor will take 3 to 6 months. And till 6 months, the patient's quality of life and LUTs will be severe. So it is not recommended. That's why we should go for same sitting procedure for prostate and stone.
Okay, Asha, he has agreed. He has said, okay, you go ahead.
so
How
remember,
will you go ahead?
sir, just a second, sir.
Yeah, what?
Remember, when you decide for bladder stone, keep bladder stone and LUTS separate. Okay. So stone needs to be removed. The decision of prostate will be taken based on the prostate irrespective of the stone. So now in this patient, forget the bladder stone. Is this patient a patient who needs prostatectomy? So there is a large prostate, there is a very thickened bladder, there is a large IPP, he has got poor flow, he's got significant symptoms. So this is a patient probably on its own merit needs prostatectomy. So I would advise this patient removal of both stone and prostate. If this patient says, no, I don't want prostatectomy, I would explain to the patient, one, he would have symptoms. There is likely of progression of the disease and there is likelihood of recurrence of vesicle calculi. Okay, if patient is okay with this, you could remove bladder stone and give medicines. But from your side, because the prostate per se needs intervention, your advice will be to remove both. Okay, as you were saying, take into consideration, say there was a 30-gram prostate with no significant bladder wall thickness and same stone, probably the treatment would be remove the stone, give medicines and see what happens in future. Okay, but with such a thick bladder, such a big prostate and such a big IPP, the possibility of this patient progressing is very high. So you should advise treatment and then let the patient take a call.
Yes.
Okay, so never say that you are going to operate because patient has bladder stones. While taking decision, segregate these two and then take a call.
So this has been explained very nicely.
Sir, I am totally agreeing with you. The decision should be taken by the size of the stone, number of the stone, size of the gland, then the effect of the gland on the bladder, that is diverticulation, saculations, and thickness of the bladder wall, and to treat both in one sitting or one at one time. Is decision to be taken based on this. If the bladder is smooth wall, no any circulations, diverticulations, or the thickness of the increase in thickness, and the size of the gland is very small, then only stone treatment is sufficient, and medical treatment for the bladder outlet obstruction if it is there. And if the stone is large size, multiple stones, prostate is also there. So it is depend upon the type of the treatment is depend upon the large stones and large prostate, small stone and large prostate, then the small stone and small prostate, and associated finding. According to that, we have to decide it is a cystolithotomy with fresh prostatectomy, or TRP with cystolithotrypsy, or only cystolithotrypsy, or the laser म्हणजे होलेप with cystolithotrypsy with the use of laser. So it is a decision based on the findings of related to the stone and its impact, prostate and its impact on the bladder.
Absolutely well said, sir.
Correct. Fine. So, Brijesh, in this case, what you will like to do? Patient has agreed. He says, I have got lots of problem. Doctor, I don't want to undergo, even if you are offering me medical management, I don't want it because I don't want 2 times surgery. I am sure that I am going to need this surgery. So, what you are going to offer me?
Sir, I would like to offer the patient transurethral cystolithotherapy with laser enucleation of the prostate.
So, okay. Now you're gone inside and you're not able to see the stone. What you will do first? Laser, cystolithography or enucleation?
Sir, if I'm not able to visualize the patient because of enlarged medial lobe, so I would, with 26 resectoscope, I would first like to resect a little bit of median lobe and make a passage for which I can visualize the calculus, sir. And then I
Anything
would
else?
like to, yes, sir.
Anything else you can do? It is a small mobile stone.
I can empty the bladder or use an helix evacuator if it.
No, you said that you are not able to see because it has gone beyond below the median lobe, correct?
Yes.
So what
So I
you will
would
do?
like to, sir, first to fill the bladder completely, and then
And then
and if I am able to visualize the stone, it's okay. But I would give a trial of helix evacuator and try to see whether it can come out.
sometimes headlock position can help, na?
Yes, yes,
The stone can be seen.
yes.
Otherwise, you might have to do the prostate first. Okay? Sometimes it happens. We can give that position and it can go. Okay, fine. So, Ankit, what you will like to do?
Sir, I will give option to the patient, uh, uh, like open prostatectomy with the open cystolithotomy, or anatomic enucleation of the prostate along with the
Ankit.
cystolithotropy.
Okay, Ankit. Such a small stone you want to do open?
No, sir.
Then?
But considering the gland size, that's why I opted for open.
So both the things. So you'll do open Frears, Millins along with which one you'll do? Frears or Millins?
Sir, Frears.
Why Frears?
Because in Frears we open the bladder and concomitantly we can tackle both stone and prostatic adenoma, bladder stone and
So
prostatic.
in Millins you cannot open the bladder?
So we can, but so in millions, bladder is usually not opened. Bladder neck is open, but
So when the bladder neck is open, you can't see inside the bladder?
we can, sir.
So very small stone, you can do both the things together. Even in millions, you can remove the prostate, and this such a small stone you can remove. But if it is a big stone, then the Frears is the ideal, because then you are opening the bladder, you are removing the stone, and then you are tackling the prostate. Understood?
Yes, sir.
Okay, so you want to do HOLEP, TULIP, bipolar, monopolar, or open? Everything is available. Patient is willing.
Sir, so first choice will be HOLEP with laser cystolithotropy, and then second option we can offer TURP with CLT, but explain the patient that he might require a second setting of TURP.
Okay.
And then third option is open prostatectomy.
Okay. Fine. Yeah, Pankaj bhai, you will
Sir,
guide
is
them.
it advisable to say TURP in 90 gram prostate, like 97 grams, 100 gram prostate in exam, sir? If they ask that to do TURP.
See.
So keep TURP as one of the last options. Don't start with TURP. That part I 100% agree with. So you should say, talk about enucleation first by any of the energy sources, probably open surgery, and then talk of two-stage TURP.
Okay.
But be clear that it would be a two-stage procedure. Okay.
Yes, sir.
Now, say if we have to talk about AEP, which laser and why? What are the pros and cons of different lasers for AEP? Let's start with what lasers can be used.
Holmium yak laser, thulium laser fiber, or thulium laser can be used.
Okay. So
And KTP also for
Haji,
KTP vaporization can be done. KTP.
Even with green light laser, they have
Green light.
described enucleation.
Yes.
So for enucleation, you can use any of the four lasers. Diode has also been described, and even bipolar enucleation can be done. Okay. So among these lasers, which would be your laser of choice?
Holmium,
Why?
because sir, it is gold standard and it is
Sir, any laser can both thulium and holmium can be considered, sir, because both are effective. The studies have proven that both are effective in laser enucleation of the prostate. No laser is superior to one and another, sir.
That's a very bold statement. Okay, so there are some advantages of each laser over other. You see, the advantage of holmium will be that it's a very good dissecting laser, good cutting laser, which also coagulates. So the advantage of thulium will be it is a brilliant cutting and brilliant coagulating laser, and TFL is a mix of both. Okay, so if there is a patient who has a significant bleeding tendency, then TFL has an advantage. If it's a very large prostate, more than 100 grams, then holmium laser has an advantage because dissection is faster. Associated stone can be treated with both TFL and holmium laser. These days, one more laser has come up, which is say a pulsed thulium laser. So that also can be used for both stone as well as prostate. So partly what you have said is right that all lasers are nearly the same, but there may be marginal advantage of one over other. Okay, but with a 100-gram prostate, probably holmium has an advantage because of the large size of the gland. What about robotic simple prostatectomy?
It can be done, sir.
So which one you like to do?
Yes, sir, I'm more comfortable with open because I have
No, robotic, which one? Freer or
Freer, sir.
why Freer?
Because in our institute I have just only seen robotic Freers only, so that's why.
Okay. Because many people say that if you want to do millings, then again you have to drop the seat. In the Freers, you just inflate the bladder, take one stitch so that the upper border is hooked to the abdomen and inside the bladder and go inside. You understand? But in millings, you have to drop the bladder. You have to dissect the bladder. You have to drop the bladder and then you have to go. So it becomes a little technically little difficult. Chances of bleeding and all these things are little more. But still, if you go to see, I have seen people doing both, and the results are same. So you can say whatever is you've seen or whatever your institute are doing. Fine. So what about bipolar? Ankit?
Yes, sir. Sir, I will explain the
Bipolar?
patient. I will explain the patient about the stage procedure because it's such a huge gland. It may take two-stage procedure for the complete removal of the adenoma.
Even in bipolar?
Sir, since although the resection rate is faster in bipolar, but there are chances the patient it may require stage procedure. I will counsel the patient about the stage before going to with bipolar 2 and inform of TRP, sir.
So can any one of you tell me this in bipolar or monopolar, what are the settings? And in thulium, I mean in a HOLEP, what are the settings? In your institute, how you keep it? When you are doing TRP, What are the settings? Coagulation, cutting.
Sir, in my institute, we use for monopolar TURP 110 cutting and 90 coagulation.
Okay. And what about, yeah, it is a spray, pure. Which one you are using?
Sir, for monopolar,
For cutting, we use pure current,
for
and coagulation, we use spray.
pure, pure and spray.
So you are using pure cutting and coagulation and spray.
If it is very hypervascular and if it is severely enlarged and inflamed prostate, then we can also use a blind current. So it will concomitantly give us a little bit of coagulation while cutting.
Okay. I think bipolar also almost the same setting.
Bipolar, same setting. Saline resection.
Okay. And Ankit,
Yes, sir.
in your institute, what about HOLEP?
Sir, usually we for incision we use a setting of 1.8 to 2 joule and frequency around 20 to 30, and for for coagulation 0.25 to 1 joule and frequency of 20 to 30 hertz. And for enucleation, sir, we may our energy setting is around 1.5 to 2, and frequency is around 30 to 30 hertz.
Pankaj bhai, you are so experienced.
No, sir.
If you
What
can,
settings is said is correct. So you will need a high power laser. The energy should be anywhere between 1.5 to 2, and frequency can be anywhere between 30 to 50. Many people would want to reduce the frequency when they are working towards the membranous urethra. During rest of the lateral lobe and the remaining of the adenoma, you may increase the frequency to around 40 to 50. Okay. For hemostasis, you need a low joules and low frequency. So usually 1 to 1.5 joules, 1 to 1.2 joules, and maybe around 15 to 25 frequency.
frequency.
Okay.
Okay.
In contrast, when you use TFL you would use at 1 joules and 40 to 60 hertz. So TFL, it is no use increasing the joules. So joules remain at 1, and frequency maximum permissible by the machine. So if you have a 40 watt or a 65 watt, based on that you can choose the frequency of TFL.
Good. तो महेश्वरी जी आप उनको खाली complications of because I'm not doing HOLEP, if you can just tell them, enumerate and just what you have come across in your thousands of cases.
So let Ankit start. Ankit seems to have seen enucleations or HOLEP. Ankit, what are the complications you have seen?
Sir, intraoperatively, we can have a bleeding. We can initially we can, in a large gland we can lose the plane of the dissection. Then there is chances of capsular perforation, or there is chances of if there is large median lobe, and during the initial cystoscopy, if we are not able to locate the ureteric orifice while dissecting the median lobe, we may injure the ureteric orifices. There is chances of bladder injury, and in early post-op there is chances of chances of hematuria with stress incontinence and dysuria, sir.
I think well covered. So the commonest complication, if you can call it a complication, would be a capsular perforation. Capsular perforations are very common during enucleation, but most often they do not have much significance because the fluid absorption, what irrigation fluid we are using is normal saline, and usually it is very easy to get rid of the extravasated normal saline. Bleeding, though rare, bleeders up till 1.5 to 2 millimeters can be coagulated with holmium laser. But if there is a significant bleeding or large bleeders, then you should convert to electrocautery and coagulate those bleeders. Ureteric orifice injury, as you very rightly said, can happen when there is a large median lobe. The precaution for that is when you are towards the bladder neck, try to fill the bladder. So when the bladder gets filled, the orifices tend to move away from you. So the risk of injury will be less. Okay. But even if injury happens, then most often these injuries do not need any treatment unless there is an extensive excision of the ureteric orifice. Mild laser burns on ureteric orifice, even ureteric catheterization is not needed. But if there is an extensive injury, you could either place a ureteric catheter or place a double J stent. Bladder injuries usually happen during morcellation. Again, they happen more commonly when you are trying to chase small pieces during morcellation. So having a good irrigation, a dual irrigation preferably, and keeping the blade continuously under vision, keeping the blade away from the wall, letting the tissue come towards the blade rather than you going towards the tissue would be the ways to reduce the risk of bladder injury. Most minor bladder injuries do not need any treatment. If there is a very major injury of the bladder mucosa, then you could use electrocautery to coagulate it or keep the catheter for a prolonged period. Somebody has written about, say, subtrigonal perforation. That is possible because many times we tend to forget that the prostatic fossa is semicircular. Means as we go towards the bladder, we need to dip down so that we remain on the capsular level. If you tend to go straight, then you may go subtrigonal. Again, if that happens, the treatment remains getting into the bladder, keeping a catheter, a larger balloon, and giving a slight amount of traction. Okay. Secondary bleedings are very rare. Infections are very rare. Incontinence post-op is possible. More often, stress, occasionally, more often urge, occasionally stress incontinence. Again, most often these recover within 3 months. Okay. The risk of stricture and bladder neck contracture is nearly the same as with other procedures. Bladder neck contracture probably is lower, especially when the adenoma is large. They are likely to happen with small adenomas.
Sir, can I ask one
Retrograde
thing?
eject.
Yes, please go ahead.
Sir, what is the concept of defocusing during Hole
Yes. So when you want to do hemostasis, okay, either you reduce the energy and reduce the frequency, or you remain slightly away from the tissue so that the hemostasis is better. If you touch the tissue, it cuts. If you are away from the tissue, it burns and causes coagulation.
Okay.
So the aim is not to cut the tissue, but to burn the tissue so that the hemostasis happens. Again, it is important to look at the bleeder. So a diffuse laser over the bleeding site may not work. You need to look at the bleeder and precisely coagulate. Sometimes if the bleeding doesn't coagulate, then you coagulate around the site of bleeders so that the feeders can get coagulated.
Thank you, sir.
Last time I showed that one video of the laser in RIRS. I think, sir, you were in at the EAU. But I showed them one video where there was a bleeder and I defocused the laser and burnt it.
Absolutely.
Sir, if it doesn't get controlled by this method, do we have to do like a DORP?
Yes. So you see, if you are unable to control bleeding by whole beam laser, you just convert to TURP,
Yes.
take a loop and coagulate. Okay.
Okay, sir.
There are a lot of centers who do electrocoagulation as a part of HOLEP. Means they would inoculate, do
Compulsory.
electrocoagulation, and then take the patient for morcellation. You see, one of the prerequisites of morcellation, other than having the bladder adequately full, is that the vision should be good. There should be no bleeding. If there is diffuse ooze, then obviously the risk of injury during morcellation will increase. So there are centers who first do electrocoagulation and then start morcellation, though usually that is not needed. So we would use it only if there is a bleeder which doesn't get controlled by a whole beam laser.
See, I think it quite nicely everything has been explained. So if you have any other questions, then ask. Otherwise, we'll conclude over here. Correct, Pankaj bhai?
Absolutely, sir.
Sir,
So
we
any
say that
question?
HOLEP is size independent, but what if we had one 250-gram prostate? Can we offer HOLEP to that patient?
So can you offer? Yes. Should you offer? That's a different question. Okay. So there are reports of HOLEP being done for more than 400 grams. The largest prostate done in India has been 676 grams. Okay. The largest prostate reported in literature is 1.4 kg. Okay. But these are very, very abnormal indications. In today's time, with the availability of robotic simple prostatectomy, I would not want to go beyond 180 to 200 grams by enucleation. Okay. The reason being your enucleation time will be very high. Further, your morcellation time will be high. So your overall intraurethral time will be high, which could lead to increased risk of stricture formation. Okay. So this decision as to what size should be done would be based on your expertise and your availability of equipment. So before we had access to robotic simple prostatectomy, we would plan this procedure with enucleation in stage 1 and morcellation after 48 to 72 hours so that you could do larger prostate. Largest prostate I have done has been around 300 grams. But in today's time, I would not want to do that.
Yeah.
One thing which we have not spoken about is about Moses laser. Okay. Can somebody tell me what is Moses laser?
Moses laser is a in which the pulse is given in two waves. The initial pulse is the vapor bubble pulse, water bubble pulse, which and the second pulse is which is given. It is basically it is a two pulse wave which reduces the retropulsion and loss of energy, sir.
So retropulsion will be an impact in stones. What about prostate? So
No.
does Moses have any advantage for enucleation? So there are studies which have said that the enucleation speed and hemostasis is better with Moses. You see, Ankit, my suggestion will be use the correct terminologies. If you would have just said that Moses is a technology of pulse modulation, इतना सारा explain नहीं करना पड़ेगा, ठीक है? So pulse modulation ये word आना बहुत जरूरी है. Okay, and then you may explain if you want. So in Moses you do pulse modulation in which there is a first small pulse which creates a vapor bubble through which the second pulse goes. Because there is no loss of energy of the second pulse, the impact of Moses laser is better. It causes better dissection, better hemostasis. So the procedure probably is faster. And there are reports that with Moses laser, you may be able to remove the catheter early and the daycare or ambulatory HOLEP is possible. Okay. There are reports of removing catheter as early as 3 hours after Moses enucleation. So these are things you should just be aware about. Don't proactively talk about it.
Who is doing this, Moses?
Lasers that you should be new things in lasers you should be aware about is Moses and pulsed thulium laser.
So Pankaj, who is doing Moses?
Moses, basically the problem with Moses is that the laser fiber is a single-use laser fiber, and it's a fairly expensive laser fiber. So we have done as initial studies, but it is really not cost effective in our situation because each fiber would cost around 50,000, around 65,000. So just to add a cost of 65,000 for a patient for enucleation is probably not justified.
Fine. So someone had asked about they wanted to know about the thickness. You are talking about the how to go about the thickness of the bladder. I think Shushank has asked about that. Can you explain him once more?
Okay. So bladder wall thickness should be measured with the bladder filled between 150 to 225 ml. On the anterior wall at 3 different places, you measure the bladder wall thickness and take a mean of 3. Okay. So the important things here is bladder should not be underfilled or overfilled, and you measure it at least 3 places. Okay. A very overfilled bladder will give you a low thickness. Underfilled bladder would give you a overly thick looking bladder. So 150 to 225 is what is considered as the optimum full.
Fine.
Again,
Sir,
when you combine bladder wall thickness with IPP, both together they denote bladder outlet obstruction maximally. So if a patient has bladder wall thickness more than 5 millimeter and a significant IPP, this patient urodynamically is likely to come as obstructed. So like this particular sonography which we have in our on our screen, there is a significant bladder wall thickness and a large IPP. So these can be taken as indirect signs of significant bladder outlet obstruction. Other things that you would see on sonography to look for bladder outlet obstruction are detrusor wall, detrusor weight. Okay, here you calculate the volume of the bladder with a marking of the outer wall of the bladder shadow. Then again calculate with the inner wall and subtract from inner from outer. The normal bladder weight is 35 grams. So less than 35 grams is considered as non-obstructed. More than 35 grams is considered as obstructed. Other things which can be seen to look for, so non-invasive way of looking for bladder outlet obstruction, bladder wall thickness, IPP, upper tract obstruction, associated diverticular saccules, then your bladder weight. Then you can look at prostatourethral angle. So that usually is looked at in the on truss. You can look at what is called as PICAR, presumed PCR, circle area ratio. So what you do is you draw a circle over the prostate, a circle with the diameter of the largest size of the prostate. And then you look at the area of that circle and the area of the prostate and look at the ratio of these two. So if the ratio is more than 80%, that's a sign of obstruction. So what they mean is the more circular the prostate is, the more obstructing it is likely to be. So PICAR is one more thing that you look at in sonography to look for bladder outlet obstruction. Anything else?
Sir, what is the learning curve for HOLEP?
So by the book, the learning curve is around 40 to 60 cases. Okay. It also depends on, say, what your means. Somebody who is good in TRP may be able to learn it faster. From learning curve point of view, TFL has a slight advantage because course correction is easier in TFL. Like in Holmium laser, you have to be between the adenoma and capsule continuously. But in TFL, if you get in the tissue, ablating the intervening tissue and again coming back on the capsule is easier. So they say TFL may have one advantage, minor advantage of having a shorter learning curve. So with TFL, they say around 30 to 40 cases. With Holmium laser, they say around 40 to 60 cases.
But with these, now you are able to see now on the screen video. Definitely, earlier it was like 40, 60. Now little less number of cases. Because if you see Dr. Maheshwari doing every day, you have seen him doing 100 cases, then your learning curve will be little less. Always. Fine. So any other questions? Otherwise, we'll conclude over here. Okay. Pankaj bhai, thank you very much. Very good discussion. All these
Excellent
questions
discussion,
are
sir.
asked in exams, so you are also aware of this. And we don't want our students to fumble when they are answering an exam. So good discussion. Thank you very much.
Thank you,
Thank
sir.
you,
Gaurang,
sir.
thank you very
Thank you
much.
very much, sir.
Thank you,
Hiren,
Excellent, sir.
thank you
Good.
very much.
Gite, sir.
Thank
Gaurang,
you, sir.
sir.
Thank you, sir.
Pankaj, sir. Good
Thank
work,
you.
sir.
And I must say that the students who are answering, They are really well prepared. They are answering
Yes,
very well.
yes, yes.
Keep it
They are
up.
reading very well.
And I request other students also to participate. So it will help them a lot.
Yes, sir.
Okay.
Yes, sir.
Good
Thank you,
night,
sir.
sir.
Good
Thank
night.
Good
you.
night, sir.
Good night, sir.
Good night.
Good
Thank you.
night, sir.
Thank
Good
you,
night,
sir.
sir.